whether you are a seasoned endocrinologist, fellow endocrinology, or consultant medical specialist, and you are passionate about hormone, your participation really enriches this gathering. So a very beautiful session and very enlightened talk, and thank you so much, the panelist and the speaker. We are moving forward toward the last session of this talk of this session, industry symposium. Role of second generation U300 glargine in the management of type 2 diabetes mellitus. For this talk, we are having a very well-known esteemed speaker, Professor Dr. Randhawa. Please, sir, join us on stage. After this, we will be moving toward our dinner and end of this today's session. Thank you, sir.
डॉक्टर सामा जब 5 मिनट बचाए थे वो यहाँ के लिए मैंने रखे थे, तो इसलिए 5 मिनट में ख़त्म करूँगा इंशाल्लाह. We will be discussing only 4 points. The safety profile of these 4 characteristics of patients. You can use Glargine 300, popularly known as Toujeo. This is the first very famous and very well-versed trial, real-eye older age group analysis, which actually is proving the fact that not only the efficacy as well as effectiveness along with the adverse events, which is hypoglycemia, is seen very less or in a similar pattern in patients who are more than even 65 years of age. You can see well beyond it, and the change of body weight was statistically marginal in both of these age groups, below 65 and above 65. Same is the case with an observational study of 80 US, and in this Toujeo study, you can see the study actually studied the hypoglycemia incidence in all the patients who are above 70 years of age, along with their effectiveness, and you can see that after the 6 months of trial, the participants below the 70 years of age as well as above the 70 years of age, both were proven very safe, this medicine, in terms of not receiving hypoglycemia as well as effective A1C control, which was marked as less than 7.5. To take the matters further, this was a switch trial from NPH to Toujeo, Glargine 300, and you can see the outcome variables were the hypoglycemia incidence in both the age group, and you can see there was 53% less hypoglycemia in the patient below and above the 65 years of age. And along with this, the duration of diabetes was studied. The patients who had diabetes of more than 13 years, in those patients who were receiving Toujeo and they were being replaced by NPH, you can see there were 51% lower hypoglycemia risk as compared to NPH. So to take the matters further, in patients with renal impairment, there was this rip-off study of real CKD analysis, and you can see all the patients of every category of CKD, the Toujeo was given, and apart from and all this, and the data proved the fact that change in A1C was across the board, they were similar. Along with it, the overall incidence of hypoglycemia was interestingly very low. As expected, the hypoglycemia slightly was seen more in patients having GFR of 15 to 44 as compared to the rest of the GFRs, and the change of body weight, as proven earlier, was minimal. And same is the case with renal subgroup ATOS, and all the same variables were studied. A1C, the dosage of basal insulin, all was similar in all the patients who had renal impairment as compared to those patients who did not have renal insufficiency in those studies, in which there was 581 participants which had history of renal insufficiency. And the second last variant, the study of type 1 diabetes with Toujeo. The study was a comparable study of RCT that was studied with Degludec in Glargine, and IDEC 100, as you all know, is not available in Pakistan. So this study was specifically studied with post-exercise hypoglycemia incidence in both these insulin types, and you can see that there was the TBR was less in U300 as compared to IDEC 100. So hypoglycemia incidence was studied, and this proved the fact that the hypoglycemia was seen less in Toujeo as compared to Degludec post-exercise. The summary of Ultraflex 1 study was 75% dosage was decreased in those patients, and both the patients and both the trial of the patients, there was no difference in terms of effectiveness and in terms of severe hypoglycemia. But over 14-day exercise period, there was no difference as well, was seen in both of these age group. And interestingly, the last of the variant, which is pregnancy, and still we are not very confident in prescribing Toujeo, but we switched the patients to U100. But pharmacovigilance study proved the fact that, as you can see, in pregnancy, IDF Atlas 11th edition in 2025 proved the fact that hypoglycemia in terms of age, it is an increasing incidence in patients having pregnancy. And you can see this pharmacovigilance study that proved the fact that patients who were receiving Toujeo and they were not being stopped or replaced with U100 or any other insulin, there was similar incidence of every adverse effect you can see, starting from abortion to post-mature and stillbirth. They were equal in both the variants, U100, which is Lantus, and U300, which is Toujeo. This is a pharmacovigilance data. It is not an RCT. So Toujeo still yet not approved, but Toujeo will in future be you can be seeing this Toujeo in pregnancy as well. So to summarize the observations in older age groups, U300 had the same achievement in terms of target HbA1c and has same hypoglycemic events. And patients with impaired renal function, you can safely prescribe U300 as compared to any other basal insulin. And type 1 diabetics have, you can see the only study that is available is comparative study for in terms of hypoglycemia. This is a non-inferior study, but yet hypoglycemia incidence was seen lesser in patients having U300. And lastly, pregnancy, glargine 100 or 300, both have similar efficacy as well as same safety, and use of 300 may be considered during pregnancy if clinically needed. Thank you.
So we were expecting a bit more probably time of the lecture, so it's ended earlier. Do you have any questions? Even if it is not put on the Slido, you can ask question directly. जी sir, जी. Mic दें, Dr. Saima को mic दें, please.
Assalamu alaikum. My name is Dr. Saima, I'm an endocrinologist from Peshawar. My question for Professor Randhawa is about the non-classical CH. Yes. We do get these patients with infertility. My question is, yes, regarding the dose you mentioned that we can give in smaller than the classical CH. And my question is actually, if they conceive, should we continue the steroid throughout the pregnancy or we can taper off?
इसके दो मैडम एस्पेक्ट्स हैं. एक्सेलेंट क्वेश्चन. हाइड्रोकॉर्टिसोन डेफिनेटली आपने कंटिन्यू करनी है बिकॉज इट्स टोटली सेफ. प्लासेंटल ट्रांसफर है नहीं इसका. जो झगड़ा आता है वो डेक्सामेथासोन का है. एक स्टडी थी जब हमारा एग्जाम्स हो रहा था, उस वक्त भी झगड़ा था, मैं पढ़ने लगा था. इट वॉज वे 12 years बैक, और वो रेफरेंस कहीं और नहीं मिलता ऑक्सफोर्ड में. कुछ रिकमेंडेशंस कहती हैं आप ना प्री कंसेप्शन डेक्सामेथासोन पे डाल दें बिकॉज वो प्लासेंटल ट्रांसफर होगा, और वो ना वो जो फीटस है अगर उसका जेंडर अभी तक पता नहीं चला, वो आप NIPT से पता करते हैं 5वें हफ्ते में. जब तक नहीं पता चलता तो आप डेक्सामेथासोन दें ताकि एक्सेस एंड्रोजन्स का इफेक्ट उस पर ख़त्म हो जाए. और 5th वीक पे इफ द फीटस इज टर्न्ड आउट टू बी मेल तो आप उसको बंद कर दें, और फीमेल है तो डेक्सामेथासोन 20 mg 3 डिवाइडेड डोजेस पे आप टिल डिलीवरी दें. और प्रॉब्लली ये वाहिद ऐसी शरण कंडीशन है जिसमें आप बच्चे का जेंडर जल्दी पता कर सकते हैं, वरना तो हर जगह इलीगल है. तो पॉइंट सिर्फ इतना है, इसके अंदर भी डिफरेंसेस. इसकी वजह ये प्लासेंटल एरोमेटेज कुदरत ने सिस्टम दिया हुआ है. यू कैन स्टिल बी गिविंग हाइड्रोकॉर्टिसोन, और ये मिक्सड व्यू है. हाइड्रोकॉर्टिसोन सेफ है, उतनी डोज पे दें जस्ट लाइक एड्रिनल क्राइसिस में हम देते हैं. दिस नो फिक्स डोज. 15 to 30 3 डिवाइडेड डोजेस मिनिमम दिया करें इसमें एज कम्पेयर टू 2. और कभी कभी ऐसा भी जरूरत होती है कि 3 डिवाइडेड डोजेस के बावजूद प्रोजेस्ट्रोजन लेस देन 0.6 नहीं होता. यू गिव प्रेडनिसोलोन रात को 3 milligram.
Okay, so it's same for non-classical.
सेम नॉन क्लासिकल. लेकिन नॉन क्लासिकल के अंदर हार्डली, हालांकि मैं आपसे कम पेशेंट देखता हूँ इसलिए इतने ज़्यादा पेशेंट आते नहीं मेरे पास, तो उसके अंदर जितने भी नॉन क्लासिकल CH हैं वो PCOS की तरह प्रेग्नेंट हो जाते हैं. मेरा तो अपना ख्याल है, लेकिन यू माइट डिसएग्री. लेकिन हाँ, PCOS जैसा खुर्शीद साहब ने कहा था, PCOS काफ़ी एक मस्करेड है, और नॉन क्लासिकल CH काफ़ी PCOS बन के इधर उधर फिर रहे हैं आम इंसानों की तरह. उसको पकड़ना है.
सर पकड़ा हुआ है.
Well, my name is Nawaz, and I have got a question for Dr. Fahim.
Fahim?
Fahim, we said that adversity never comes alone. The subject of the MASH, it's a basically constellation of signs and symptoms. You start from the fatty liver, you end up with a disease complication of diabetes and cardiovascular bad outcomes. Already we are very much burdened with the anti-lipids, with the uric acid drugs. So should we be adding something like resmetirom to the already overburdened patient who is taking antiplatelets and or should we be clearly defined about this situation that when you are adding something to the fatty liver, when it is not associated with the diabetes, and something like when it is associated with the diabetes. So it's a more of a jingle and it's a more of a puzzling rather than simply projecting the data that this medication has shown something. Would you like to enlighten it?
सर ऐसा है जो रेस्मेटाटॉन की आप बात कर रहे हैं दैट इज़ बेसिकली अ ड्रग दैट हैज़ बीन लाइसेंस्ड फॉर मैश which is a biopsy proven condition. So if you are going to the extent that you want to confirm the inflammation plus the fibrosis plus the things going on, there is low ballooning and fibrosis and lobar fibrosis and all these things, then there is a logic that you should treat that. The resmetirom is not being licensed for just metabolic dysfunction or fatty liver. So that is a misconception that the people think that most of our healthcare provider thinks that this is a drug for fatty liver. This is not a drug for fatty liver. The other thing, the good thing to the situation is that the drug we are already using, like semaglutide and maybe the tirzepatide and maybe empagliflozin and dapagliflozin, they have now an impact on the liver as well. And the message was basically that only we should not be just looking for A1C or liver or heart and renal. We should consider now fatty liver is an additional thing that we should be at least considering. आपके पास एक patient है and now we have diabetes and fatty liver. We have a patient with diabetes and obesity. We do consider semaglutide if the patient can afford. But if we have a diabetes and fatty liver, or we may not consider semaglutide in that group of patients. So at least with the upcoming data, this thing should be considered that it is a possibility that rather than just focusing on semaglutide for obesity or weight loss or diabetes control, why not we should consider this drug being a part of a treatment of the fatty liver as well. And once we talk about the newer drugs that will be specifically licensed, as I said in my presentation, that there is no drug licensed for MSLD. The drug that is licensed is for MASH. So if you have a biopsy proven evidence, then well and good, we can go for this drug, an additional thing. But if we don't have, or most of the time we don't have, we see a patient with fatty liver every day. But we never consider it. हम उसे कहते हैं कि बस वज़न कम करें, डाइट पर ख्याल करें, ये करें. So instead of just thinking on those lines, we should consider this an additional indication of thinking and starting these patients on these drugs rather than going for the same DPP-4 or sulfonylurea for looking for the glycemic control. Because the MSLD is very easy to define now. Diabetes, fatty liver and ultrasound, this is MSLD. And we should consider drugs that can help in MSLD rather than just ignoring it altogether. So yes, sir.
Thank you so much. This is the end of today's session. Every good thing comes to an end. So all you probably dropping your blood glucose level to your boots. So kindly join us for dinner in the Chinar Hall, which is by Hilton Pharmaceutical Company. And thank you again.
Thank you for a wonderful session. Fawad, you have given a very short talk, so you can't run away. So come back, please. Fawad, your very nice and concise talk, your final talk on U300.
सीख रहा हूँ सर मैं अभी.
The talk which you gave, and you said the data was in IDF Atlas as pharmacovigilance, and probably the company itself can give us more view about it. The size of the molecule itself has got a more affinity to growth hormone, you know that. And whether that will cause macrosomic babies, or did it show for particularly for pregnancy? Was there any evidence to that? Was it checked at all? Because really, it is pain when you have to change the medication during pregnancy from glargine to the other Levemir and so on and so forth. But it'll be reassuring that there was no macrosomic babies in the pharmacovigilance studies.
सर जो डाटा दैट वाज प्रेजेंटेड टू मी, जो मैंने खुद डाटा भी स्टडी किया था, मैक्रोसोमिया वाज नॉट सीन characteristically more in patients having U300 as compared to U100. लेकिन still ये अभी तक इसलिए that's the way the reason why it is not being approved. It might get approved in later part of the year. यही एक issue था कि U100 is totally safe and why not U300? But the same concerns in this PV studies, they actually showed there was no additional side effects in any kind in fetus or in post delivery complications like macrosomia or even SBDs or abortions. They were statistically similar and they were close to being none. So that's why they presented that study. But yet there has to be more studies which can make it approved. I still think this will take a way ahead, that Tojo would be approved before 1 or 2 years, I don't know, but most likely that study is suggestive of the fact we can continue this thing just like new mercazole. If the patient presents in at 12th week, you cannot switch it to procarbazole because the damage as well. That could be the main reason.
Thank you.
Yeah, just one very quick comment. Even if you look at insulin glargine U100, it's not approved for pregnancy. The recommendations are if patient is already using glargine and HbA1c is stable, there's no reason to switch back to datamir on that patient. You can stay with glargine. And I think most likely with the data coming up, U300 will get the same. The real problem with the glargine was some kind of affinity it has for IGF-1, for growth hormone receptors. That's why FDA hasn't been very comfortable and they need more and they keep asking for more data. But as of now, that's where it stands. Thank you.
Thank you. Thank you, sir.
All senior executive members are requested to join us for a group photo on the stage, and rest you can join the dinner in Chinar Hall by Hilton Pharma.